to all of you mandibular advancement device. The mandibular advancement device has evolved into a more enhanced precision wing, in which it is more stable, it is sturdier, it's longer, and it's easier to use. And as said in the morning, it is advancing to the 5 blocks, which is even more suitable for practice cephalic with heavy masseter muscles. So what is good about the mandibular advancement that is very practical for teens nowadays to utilize the device and the feature together with teen treatments. The mandibular advancement is not only a functional appliance in this one. Together, we're able to use the precision wing to induce the class 2 correction in single or multiple jaws. So it's more comfy. It's more favorable to the teenagers. They're more able to adapt to a forward position rather than one jump edge to edge, which makes it really hard and very challenging for them to be compliant and wearing it for a whole day. So as you can imagine with those 5 blocks, twin blocks, not 5 blocks, twin blocks or activator, usually we need a construction line. So it's like one jump, edge to edge. So it's very ouchy for the patient, and you want them to keep it on for 24 hours. It makes it hard for them, to be very compliant, and the treatment won't be very predictable, and the success rate of functional appliance is not very promising in the earlier days. However, now with the advances in mandibular advancement, after 2000, I believe like 2009 or 2019 or 2018, with the introduction of the mandibular advancement, it favors a lot of teen treatments in class 2 malocclusions. So besides the mandibular advancement, it is also applicable to do leveling and alignment at the same time. So it's like skeletal, dental, and also arch expansion. So it's like 3 in all. It's not only functional appliance first, and then we do leveling alignment, and then we do arch expansion. Maybe previously the transfers had to be corrected. So in the earlier days, we have to correct the transfers, and then the AP, and then the leveling alignment, and then you need 3 devices. You need the arch expansion, the arch expander, the RPE, and then after they finish with the arch expander, they have to switch to a twin block or activator device. And then they do the bracket system, which makes it very difficult and challenging for patients with class 2 mandibular retrorhnatism to go into treatment and in good treatment. However, now we are able to combine the 3 different approaches together at the same time, and we're going to save a lot of time, which is more efficient and it's more precise for the patient. So we are able to do all 3 together: the skeletal, the arch expansion, and the dental treatment at the same time, without waiting for any different plane of order of correction. However, with mandibular advancement, it's a functional appliance. So it's separated into different stages, unlike treating only for crowdings or for large overjets. It's divided into the active phase, the supportive phase, and the retentive phase, because you need time for the mandible to grow. So if the alignment is good, the upper and lower incisors are in good alignment, not too crooked, the molars are not really tilted or not buccal version or lingual version, then you are able to start the mandibular advancement device right away. However, if the molars are a little bit derotated, we need to derotate it first. And then we are able to start the MA phase. The MA phase lasts for 6 to 9 months. The goal is to reduce the large overjet and to correct to nearly class 1. You don't have to go to class 1, but nearly class 1. Okay, less than half class 2. That is our goal. So that is easier for the phase 2 treatment, or it's easier for the final detailing and finishing. And then the MA phase, it will take about 6 to 9 months. According to my experience, it should last for about a year to be stable because it takes time for the condyle to grow. And if the time is not sufficient, the condyle won't be stable. It will relapse back into a more distal position. So after the mandible position is set in an edge-to-edge position, hold it there for some time, for at least 3 months. And then you do the posterior settling at the same time. Then you go into the supportive phase, the second phase of functional appliance with Invisalign. It will take about 3 months, usually 3 to 6 months. And at this stage, after the mandible is stabilized in a more forward position or edge-to-edge position, we hold the mandible there, we support it there, and then we allow the posterior premolars and molars to erupt. Because usually when you advance the mandible, what happens on the posterior? There will be open bite. It's common. The more severe the overjet, the larger the posterior open bite. If you do a lot of MA and you don't have posterior open bite, something is wrong. You have to live with posterior open bite when you're treating MA. Because after the mandible advances, okay, the curve of speed is still deep. Because all the plastic is covering the occlusal surfaces on the upper and lower arch. It's different from activator from twin block. Because with activator and twin block, when the patient comes back for a follow-up, we remove the acrylic to create a freeway space for the passive eruption to continue during the wear of the twin block and activator. However, with mandible advancement, we are not able to do that together when they have the precision wing in mouth. We have to do that at the later stage. So during the supportive phase is the phase when we induce the passive posterior eruption to attain a good interdigitation of the upper and lower posterior occlusion. And then after all the teeth come into contact with each other on the anterior, on the posterior, then we enter a retentive phase. During the retentive phase, we need to hold the mandible a little bit more forward because usually with severe class 2 mandibular retrognathic patients, the mandible tend to relapse back 1 to 2 millimeters after the mandible is brought to an edge-to-edge. That's why usually in my cases, with overjet more than 6 millimeters, I will set the final position with the lower incisors 2 millimeters in front of the upper incisor to counteract for the relapse that will happen in the future. Because with Invisalign, everything is not enough. Everything is underestimated. So we need to over-correct or over-engineer, over-treatment in order to get to 100%. If the first clean check is only 70 to 75% accurate, we can get to 125 to 130% on the clean check to get 100% clinically. That is what we have to do with digital orthodontics. With digital orthodontics, we have to calculate or we have to foresee and treatment plan the differences between what will happen clinically and what is on the clean check. So during the retentive phase, we can start to reduce wear. That is the time when the patients are really happy, They just have to wear their aligners at night. They don't have to wear it in the morning because we want to check and monitor how their stability is. If you ask the patient to wear the wings, all the time, sometimes it gets over-treated and the mandible grows too much. So we have to free the mandible at some point of the time and to see how much relapse it goes back. If it gets back too much, we can give the patient the class 2 elastics or the bi-wrap to allow the mandible to slide forward a little bit. So usually with patients undergoing mandibular advancement after the treatment, I will give them Vivera with the bi-wrap. So the bi-wrap will serve as the nighttime activation and it will continue, okay? So the criteria for MA are as follows. Skeletally, it has to be low angle cases. In high angle cases, it's not suitable to use mandibular advancement because it will make the face even dolichocephalic, and will make it even long face. And they will tend to be called the horse face in Chinese. The more MA you give to dolichocephalic patients, the more longer the lower facial height it will be, because you are going to elevate the vertical dimension. So usually the MA is suitable for low ankle cases. However, mandibular advancement in Invisalign can be used for other occasions or other situation or scenario. It can also be used as a bite opener. You can open the bite with the MA because it's really flexible and soft. Sometimes you can open up the bite to flatten the curvacity of the lower arch, or you can open up the bite to correct severe crowding to reduce the friction, so that the high canines and instantly laterals are easier to resolve the crowding. So MA is not always used for functional appliance. Even a lot of doctors are using MA in adult patients to open up the bite. It's really very efficient, and it's another topic. A lot of doctors are sharing how to use the the mandibular advancement to utilize it as a bite opening feature in a lot of adult severe deep bite cases. And it's usually good for mandibular retrognathison patients with weak mandible in a class 2 canine and molar relationship with a lack of vertical height. Usually these patients have a more distal position of the mandible in which you don't see the chin, and the chin is facing backward. Those type of patients are good candidates for MA. And if you treat them during or before, 1 year before their puberty and 1 year after the puberty, it's a good time to utilize the MA in this type of growing patient. It's gonna adapt, or it's gonna change their facial profile a lot. However, in mixed dentition, you are able to correct to class 1. However, it takes time for patients in the first package to grow the chin. It will not happen, just like, patients in their 12 to 14 years of age. And we're going to look at some cases with the MA. So, in a dental aspect, usually patients in the late mixed dentition and early permanent dentition are good candidates for MA, and with some crowding and well-aligned cases are easier to go into MA rather than enter another stage called the pre-MA. Pre-MA, you can foresee it as a stage to do some leveling and alignment, so that when you engage the precision wings, it does not interfere with the jaw. Because with the jaw, everything, the dentition has to be slightly straightened, or only mild crowding. If it's very crowded, it's hard for the jaw to jump forward, because there will be a lot of interferences and there will be a lot of collisions on the upper and lower arch. No labial, no labial tipping of lower incisors. If there's a lot of labial tipping of lower incisors, when you advance, it's gonna tip even more, okay? So if you have severe labial tipping of lower incisor to start with, maybe you want to jump at the same time correct the labial tipping, because the contraindication or the side effect of activator or twin block or functional appliances is the lower incisor tipping. That is a very commonly seen contraindications of functional appliances. However, I think with aligners, it is doing a good job to hold the lower incisors from too much labial tipping, because you're able to engage all the plastic wrap over the lower incisors and to prevent them from too much labial tipping at the end of the jaw. And any candidate with an overbite less than 7 millimeter and large overjet of between 5 to 7 are good candidates for the mandibular advancement. So the case selection are as follows. You can look for your patients with large overjet, with deep bite, and with a weak mandible. Any patients with skeletal class 2, dental class 1. Okay? Or dental class 2, skeletal class 2 are all good candidates for mandibular advancement, but not dolichocephalic patients. So we can look for patients as follows. You can look for a patient with a weak mandible, okay? But the skeletal looks great, nice, okay? And you know that you don't have to put the patient under MA for long, okay? And the mandible will advance. The second type of patient is this type, looks like, there's some ulcer in it, a very small chin, mouth reserve, okay, and small eyes, okay, and the iris is on the lower of the eyeball. Usually are this type of patients with a deep overbite, and the overjet is good, not too large, and a mouth reserve. And the third type is any patients with large overjet, in which if we are able to tackle it with some functional appliances, we're able to bring the patient near to class 1. As long as we're able to correct the patient from a severe class 2 and on class 2 to a near class 1, it makes the rest of the treatment easier. You don't have to do the extraction, and the case is less complicated, and maybe we don't have to do any TADs, or we can utilize less elastics in the patient, and to give a patient a better facial profile at the end of the treatment, and giving them a change in the facial profile. And this will change your life and change your health as well. As you can see, a lot of class 2 patients with a small chin, a small mandible, usually 95% and above, have some problems with the air, have some problems with breathing, have some problems of their soft tissue, myofunctional discrepancy. So let's take a look at the first case with an excessive overjet in which we utilize the mandibular advancement, the precision wings, for the treatment. So this is the boy that comes in. He's in his middle school, okay? He's about 15 to 16 years of age with problems of smolder clogging on the anterior upper incisors, okay? A very deep proboscis, some cloggings on the lower anterior, okay? And on class 2, okay? Almost and on class 2. So we can assume that the overjet or the AP correction is about 4 millimeter distalization. However, the overjet is more than 4, but we know with this type of NI, because a canine is usually 8 millimeter in width. So by looking at the canine, we know that to bring this canine tip to this place, it takes about 4 millimeter of distalization on this side. And on this side, maybe about 2 to 3 millimeter. So you need about how many jumps? Maybe 2 jumps for the patient. And the overjet is severe and the proboscis is large. So he has issues of crowding, large overjet, and mandibular retrorhombathism. So we want to use MA together with the arch expansion mechanics in which we are able to incorporate with MA to treat him. So you don't have to wait. You can do the transverse correction and the AP correction at the same time, okay? However, when you're doing MA, you are not able to do distalization because there's 2 different directions. One, you want to advance, and the upper you want to distalize. You cannot do that because there's the precision wing on the upper arch and another precision wing on the lower arch. So it's hard for the material to be squeezed back and then together with the wing. So you have to do it, step by step. Usually we do the mandibular advancement first. And then after we achieve an edge-to-edge position, we see how much relaxed the mandible is. And then with the residual overjet, you can utilize with class 2 elastics or distalization for the second phase. Or after the MA treatment, you can continue with the class 2 elastic together with distalization protocol to fix the residual relapse of the canine relationship. And we did three clean checks, yes. 3 clean checks for the patient, and it took about 2 years to finish his case. And after he finished case, he went to the Philippines to study medical, okay? Because he is more confident of himself, and he is more assured of himself. He thinks he looks better, and he is more healthy. So he is a class 2, division 1, in which all the upper incisors are flaring on the upper arch, with problems of lower crowding on the lower arch, excessive overjet of about 10, narrow arches on the upper arch and lower arch, with mandibular retronatism on the chin button, and the chin is deviated to the right. Look at this. And we need to take note of that. We should have good eyes, because usually with patients in class 2, mandibular deficiency, if you don't correct it early in life, they have skeletal asymmetry. This is very evident in class 2 and in class 3 until class 5. You know why there's a lot of asymmetrical skeletal problems in patients with class 3? It's because the mandible is locked in an anterior cross-back position when they're young, and the condyles are not able to naturally grow symmetrically. And then, you hinder the growth on one side, and on the other side, it continues to grow. That's why usually the mandible, after the patient in class 3, after they have been grown up into adult, the mandible is asymmetrical, and they have to go into surgery. So the concept nowadays is, do not wait for the class 3 to finish growth and then go into treatment. We need to treat early to decrease the chance that the patient may have a deviated chin and go into surgery later in life. And he's a mouth breather. Okay. So you can see the overjet is 10. How are you going to do this case without extraction? Impossible. I don't think I can use class 2 elastic in him with overjet of 10 and finish him. Maybe I will, finish with an end on class 2, and then with finish with an overjet of about 6 millimeter. If I can retract or distalize 4 millimeter, I think I'm already very superwoman. However, with 10, I don't think I'm able to, distalize 8 millimeter with just segmental distalization or with just distalization with class 2. So the only way is to advance the mandible and change the canine relationship into a near class 1. That's what we want. That's our treatment goal. Because everything is class 1. Class 1 is canine guidance. If you're looking for any relationship and you're in conflict, whether to finish with a canine class 1 or a molar class 1, always choose canine. Canine class 1, however, molar class 2. Okay? That is usually how we do it and how we plan with patients that are, a little bit in conflict. Whether you have one incisor missing, or you have asymmetrical missing teeth, asymmetrical missing tooth with this bolted discrepancy, and you're not able to finish, both sides at class 1, canine and molar, then maybe you choose canine instead of molar as the finishing class 1, as the class 1 for the finishing stage. And the overlap is okay, about 4, okay? So we are looking for 10 to finish at 2.7 millimeter overjet with a decrease of 7.3 millimeter. This is impossible with just class 2 elastic, so we have to do this with mandibular advancement feature with the jump. So this is the patient, the panoramic. You can see the 8 are still intact. Okay. However, let's examine the ramus height. Look at the ramus height. On the panoramic, there's a lot of information. It's just whether your eye sees it or not. You don't need to have a CT or a SIG just a panoramic, you can see a lot of stuff, a lot of information. You can see whether the nose is stuck or not. Look at this. It's more cloudy here. However, the nostril is wider here, but narrow here. Okay, you can see, with the characteristic of the nose, and you can tell whether which side is more stuck and stuffy. Okay, and with the ramus, you are able to measure the length, okay, the height of the ramus, and see whether there's a difference, in the skeletal structure. If there's a difference during the teenage years, especially between 12 to 16, just free the mandible and allow the conduct here, and the glenoid fossa here to grow. However, if it's stuck, okay, in a posterior position, it's hard for the mandible, for the conduct to grow in length, because this is the growth center here, and the menton here is the growth center. So it grows in length and grows in length here. So there's a difference in the ramus height on the right and on the left. That's why the patient, the chin is more deviated to the right. So look at his chin. It's deviated to the right. So the treatment plan is to do upper arch and lower arch expansion, and especially on the lower arch. Because the wider the transverse on the lower arch, the better it is to jump out. Because we don't want it to be tucked inside. With a lot of collision and a lot of interference over the premolar and molar region. And we need to utilize the MA with a symmetrical jump together with myofunctional therapy for the kid, to teach him to use his nose to breathe instead of his mouth. So let's take a look at his clean check, the first clean check. Okay. So on the first set of clean check, there were only 35 aligners. Okay? And then we did one jump or two jumps. And the final position, okay, I set it at 2 millimeter in front of the upper incisor. The lower incisor 2 millimeters, because it's a very severe overjet. It's about 10. He is a candidate for surgery in my early days of orthodontic training. However, now with the advances in the functional appliance treatment, we're able to give him another chance to correct his mandibular precision. So the end point, I set it, the lower incisors 2 millimeters in front of upper incisor. But this does not mean that he will end up in a crossbite. It only means that he is more able to attain end-to-end, edge-to-edge position. Because we know that clean check is not 100% accurate. It's only 70 to 75%. So I add extra. And in this sense, we are more able to help the patient hold the mandible in a more forward position. Because usually the more issues that a lot of doctors are getting is the wings get crumped. The wings get crushed easily. The wing gets bitten easily. Because usually with low facial height, these type of patients have very heavy masseter force. So the muscles itself will crumple and crush the wings. It's not their teeth only. Can you imagine how much force we need to move a tooth? About 2.0 grams. Right? You know how much force the tongue exerts on the tooth? 500 grams. The lips, 250 grams. That's why myofunctional is very popular now, because it explains everything. Why teeth gets relaxed after we have done orthodontic treatment? Because the muscles are not stable. And it is the last piece of the puzzle for orthodontic treatment. So if you believe in muscle influence on orthodontic treatment, you will know that everything will explain itself. So we need to train the muscle to be more balanced and to decrease the active force or the hyperactivitiness in the muscle force. So how do you set up when you do the submission? Under the AP correction, you want to correct the class 1, canine and molar relationship, and you click on mandible advancement. There is an option that you can select. You have 3 options, either edge to edge. This is usually the default, the edge to edge position, but it's not strong enough. It's not powerful enough. It's only 75% correct and accurate. So I don't like it because usually I have patients that are very severe and with a large overjet. So I would usually go for a lower arc 2 millimeter beyond edge to edge. I don't usually use the 1 millimeter because when the patient comes back and when I monitor, I would check, okay? If they are already at a good position, we don't have to use the aligners after the patient haven't finished. But usually how do you check if the bone started to grow over the condyle? You need to push back, push the chin. Okay, tell the patient to bite, because usually with patients under mandibular advancement treatment, they tend to have dual bite. They tend to bite here and here, and they don't know where to bite because they don't have a good posterior interdigitation. That's why they have a dual bite. So with the dual bite, you never understand and you never know whether they have achieved a stable mandibular position. So the best way to do or to check is to push the chin backward. If it's easy to push backward and the patient, has a more posterior interdigitation, that means you need to continue with the supportive face. That means you need to hold the mandible in a more forward position longer. That means the bone haven't, developed or the bone haven't grown enough. So maybe give another 3 to 6 months for the mandible to stabilize or to get into the edge-to-edge position to be more retentive there at that position. However, if you push back the chin and so hard, you need to use all your force, all your body to push the chin, and it cannot be pushed back, that is good. That means the patient, the condyle has been growing and it's in a good stable position. That is one of the clinical checkup that I will use or that I will utilize clinically to check whether the patient is in a good mandibular supportive phase or whether I can go on to the next phase. Can I give the patient retainers yet? I will check whether the chin will go back. It's an easy way. And a lot of doctors, they don't know about that. But now, today, you go home and then you know how to do MA in an easier way. And with the advancement, you have 2 options. You can use 2 millimeter, okay, advancement to the end of MA or single advancement. If the patient, the wings gets crushed easily, okay, and you have a lot of issue with the patient, and the patient, is always fighting the wings, and the wing gets crushed easily, that means the patient has very heavy masseter force. It's better to go into AA and then choose this one, single advancement to the end of MA phase. That means the patient will get a new pair of precision wings that are longer and that will engage, because if the wings are longer, the plane of the wings, the border or the sides of the wing will be longer, and the engagement, the advancement of the mandible has to be more forward, so it won't get crushed easily because the wings are longer and sturdier and more retentive. So if the wings get crushed easily, then we have to do the single advancement. Usually I do it in patients with severe deep bite, not overjet, severe debug. They crush the wings very easily because the masseter muscles are so hyperactive. The wings cannot resist the force of the masseter muscles. So after 6 months, are you amazed? Alignment, and the patient is in canine class 1 in just 6 months. You never seen that with twin block or activator, because with twin block or activator, you need to do the grounding or leveling and alignment first before you give them the activator or the twin block. And it will take about at least 8 months. The shortest you will see is at least 8 months. So usually, when I was still in the ortho program, we put 2x4 brackets, and then after that we use activator to advance the manual. So it will take a lot of time. And with the activator, it's very bulky, and the patient hates it. They don't like it. They don't want to come back for a visit, and they don't want to wear it. And now with the mandible advancement, it's very promising. I stopped to use functional appliance after I graduated from the orthodontic program. Not only after the launch of MA, I started to treat kids. After I got certified in 2009, I don't usually have a lot of kids. I only treat adults, and only those kids with 7 erupted. I don't treat kids with only 6 to 6, because we can see that with a lot of kids with 6 to 6 erupted, after we finish the treatment, when the 7 started to erupt, it erupted into a crossbite. I never knew about the reason why, but after we are able to do the pincher review and modification, I started to realize that we don't do enough expansion on the molars, especially the 6. That's why the 7, the intermolar width for 7, is not wide enough to accommodate the erupting 7 into position. That's why they grow inward, lingually on the lower and buccally on the upper. And if the 8s are also erupting, they both fight against each other for a space to come out. So they just, we call it, they just grow anywhere they want. With less bone, they come out. And then with mandible advancement, we are going to see a lot of jump. The more jump there is, the more severe the malocclusion, the larger the overjet, okay? And for every jump, okay, it's 8 aligners. And after we finish the jump, there will be a stage called the transitional bite or the treatment goal. Usually with the transitional bite, the light blue, don't change every 7 days, because you need time to cook. You need time for the bone to grow. For the transitional bite, I usually ask my patient to wear 1 month. Before, I always ask 2 weeks to 3 weeks, but I find it is not enough. So nowadays, I usually ask them to wear 1 month, 1 month, 1 month, 1 month, 4 months. After 4 months, they come back. The bone and the mandible is more stable, okay? If after you push, they go back easily, they have to wear whole day. If it's very strong, okay, it doesn't go back, they can wear at night. That is how I differentiate and how I ask my patient to continue their aligner wear and prescribe them good a good wearing protocol during the transitional stage for the aligners. So 1 jump is 2 millimeters, okay? And more excessive the overjet, more jumps there will be. And more excessive the overjet, you have to finish with the lower incisors 2 millimeters in front of the upper incisor. So with overjet, more than 6 millimeters, finish with 2 millimeters in front of upper incisors. Anything less than 6 millimeters, you can finish with an edge to edge. It's good. Less severe, you can finish at edge to edge. But with more severe overjet, they tend to relapse, okay? Why they relapse? Because the bone does not grow in time. You see, larger the overjet, more bone, it needs to grow. It needs to grow more bone, or else it won't be stable. The condyle has to be solid in order, to lock the mandible in a forward position. If the condyle is not solid, it tends to relax. And the larger the overjet, the longer the time it takes for the patient to grow bone around the condyle area. And the more retrographic the mandible, the longer the MA phase. So a lot of doctors will ask, oh, Dr. Maggie, how long should I put the patient under MA? It depends. I don't know either. It's dependent on each patient, according to their facial type, according to their overjet, and according to their curve speed. The more severe the curve speed, the more posterior open bite you'll get. So for him, the first order, the AA2, I set the final position at 2 millimeter beyond edge to edge. This does not apply to all patients under MA. It only applies to patients with an overjet more than 6 millimeter. Less than 6 millimeter, I usually have the patient bite at edge to edge. I don't usually use 1 millimeter in front. I use edge to edge and 2 millimeter in front. Okay? Because he's rather severe. He has a 10 millimeter of overjet to start with. And look at him at 1 year and 6 months. What happens? His chin relaxed a little bit back. You see, this is what? Class 1. A little bit class 2. The chin will what? Will move back a little bit. Because with MA, it's not stable if there's not enough time for the bone to grow. So at this stage, I know that there's open bite. It's good. This one, not too much open bite. I know I need more because the curve speed is deep. Okay? If there is more advancement to the anterior, there is more room for growth and more room for the vertical height. For posterior open bite, accept it with MA treatment. Because it's even more common than distalization. And you need to have posterior open bite, or else the mandible will not advance in a forward position. That means your MA is ineffective. If it's effective and it's predictable, you will get the open bite here. Okay? But how to deal with posterior open bite with MA features? If the gap is less than 2 millimeter, somewhat like this, okay? 2 millimeter is like 2 round birds, 2 small round birds, 2 millimeter, okay? Trim the aligner distal to the gap. So if it is posterior, distal of this second premolar, we cut it between 5 and 6. Cut it between 5 and 6. So there's no plastic coverage over 6 and 7. 6 and 7 is free, nothing. So the aligner, you only wear 5 to 5. Get it? Okay. Why? Because you need clearance for the teeth to come into position. If you wrap plastic over it, it cannot what? It cannot touch each other. So by cutting the aligner, it's just like trimming your acrylic or trimming your activator and twin block when the patient comes back for a follow-up visit. If you want the tooth eruption to happen with twin blocks, with activator, it's the same idea. And it takes time, okay? And you can ask the patient to wear the aligner only nighttime if the mandible is stabilized in a forward position. It doesn't go back after you push. If it goes back after you push, don't cut first. Ask the patient to wear the aligner longer. And then after the mandible is more stable, then you cut and ask the patient to continue the nighttime wear. And then in this way, you're able to settle the posterior molars into position after 3 to 6 months. It depends. Some patients are faster, some patients are slower. But the criteria is the inclination has to be correct. That means there's no tipping of the molar. It has to be upright and parallel to each other. If there's tipping, it's hard for them to passively erupt. Because on the path of eruption, there's a lot of interference and friction. So if two teeth are parallel to each other, it's easy for them to erupt. But if one is more mesial tilting, there is the collision on the distal of the front teeth and on the mesial of the back teeth. And then when they erupt, it's going to interfere. There's some interference, so the second molar cannot erupt into a good position. Then you need to correct the inclination with a good attachment and the aligners. However, if the gap is between 2 to 3 millimeter, we can utilize it differently. We can use elastics. Here. You can use up and down elastics or the triangular elastics as shown earlier in the last case of the morning session. I like to utilize the triangular elastic because it's easier for the patient to wear, and it's easier to hook. It's easy to bond. And this type of clear button is also available from the manufacturer, different manufacturer. But I don't use a lot of clear because it gets debonded easily. Okay, and this one is more. This one is more pricey. It's clear bracket. So that means the doctor is fully in this line. And he has some stock of clear bracket. You can use it. It doesn't, matter if it's the lower incisor or the upper incisor. As long as you can bond it on and the patient is able to pull elastics, it's good. Or you can use the composite resin to build up a clear button as well. So if the gap is between 2 to 4, you can use up and down elastic to help settle the bite or to close the posterior open bite. However, if the gap is more than 4 millimeter, maybe we want to go into additional aligners. And a lot of issues arises because after mandibular advancement, and there's a lot of posterior open bite comes from inadequate upper extension. Oh, this is interesting. In class 2, we always think that lower arch is smaller. We need to extend the lower arch transversely and sagittally. How about the upper arch? There's not much issue of upper arch narrowness with activator and and twin block. However, with aligners, you're going to see a lot of inadequacies, especially on the upper arch over the premolar area. So let's think again. We are moving the lower 4, 5, 6 into a forward position. So the lower 6 will come into contact with the upper 5. With the upper 5 and 6. So on the upper arch is narrow there. And with the wearing of the aligner, you constrict everything together. So on the clean check, if you don't perform transverse extension on the upper arch, you will usually get a narrow upper arch with poor arch development, and you will usually get a cross bite. You'll get very narrow here because we are moving the lower posterior region, which is wider, into a narrow region on the upper arch. So can you get it? So the lower is wider, and then you're moving it into a narrow region on the upper arch. So you need to do a lot of extension on the upper second premolar and molar if you're doing a lot of MA. And this is gonna save you a lot of time. That is from my many years of experiences with the mandibular advancement feature. So if the bodily expansion is more than 2 millimeter per quadrant, we need to add overcorrection of expansion. That means if you are looking for 2 millimeter of expansion clinically, you need to see 4 millimeter on your clean check so that you can see 2 millimeter clinically. Add extra buccal root torque so that you don't get the palatal cusp hanging down. Because we know that the T or the tooth, when it expands, it does not expand like this. It expands like this. So palatal cusp is hanging out. This is the root. This is the crown. So we need to add extra buccal root torque to keep the molars upright. However, everyone is lucky nowadays because with the advances in the G8 smart force technology, we have less incidence of posterior open bite nowadays, but we can add more because with G8 sometimes it's not enough. Okay. So let's take a look at the patient's upper and lower arch. The upper and the lower arch is good. The arch form, okay, it's good. Okay. So after the patient has some posterior open bite and the upper arch is narrow, we stop for another new scan and put the patient in AA1 or the second set of aligners. And on the second set of aligners, we continue with the MA because I want to advance the mandible further because the patient is severe to start with. So with just 35 or 36 aligners on the first set of aligners, it's not good enough for him. So on the second set of aligners, we did another 34 aligners for him. So that's about 8 to 9 months extra. So as you can see here, okay, during the initial, okay, this is the final position on the final stage of the first clean check. And then after the patient finishes his upper and lower aligners, can you see the canine eminence is larger here, and the lower canine eminence is more lingually. It's more lingual version. This one is more buccal version. So the overbite and overjet over the upper left and lower left is not good. The arch development is not too ideal. They are not coordinated after advancement. Because with this type of patient with midline deviation, we usually tend to have asymmetrical jaw. That means one side is more than the other side. And if one side is more than the other side, sometimes we tend or we neglect to look at the overjet. Not the overjet. We neglect to look at the canine eminence on the final stages. And sometimes it doesn't induce the tooth movement or the tooth leveling and alignment of the tooth. Sure. Because your aligner have wings and it's also doing leveling and alignment. So if you're doing a lot of mandibular advancement, do not put a lot of bireps if you're doing MA because it will weaken the wrap of the upper incisors. So you want bireps, MA first, and then continue with bireps, but not together. It's gonna weaken the upper incisors of plastic wrap. So on the second set of additional aligner or the third scan, we coordinate the upper and lower arch and allow more lower lingual buccal out the side. I think the upper arch is wide enough. However, on the lower arch, we want more buccal portion over the lower lingual side. And this is the patient after 2 years. I think it's good. Okay. This is him. Okay. He's more able to smile better. Because with this type of patient, the muscles, especially the orbicularis muscle, they are very hypoactive. It doesn't contract. It will take a lot of exercise. So when they smile, all this the angle of the lips come down, like granny, like grandmother. So they need to train, their orbicularis muscles as well. And his skin is much better, less pimples. And this is him after the treatment with mandible advancement. Even though not the best chin button I want, but because genetically he's a very severe mandibular retrographic patient. So we just want his dentition to come into class 1 and to free his mandible in a more posterior position, backward position. Okay. And after the treatment, he went to the Philippines to further his education in medicine. So I'm really happy for him, and look at how his mandible is able to auto-correct and self-correct after we're able to free the mandible. And he has the chance to grow more on the side that is short, with a shorter ramus height. And this is his panoramic before and after the treatment. The 8 are still intact. Okay, so pay close attention here, because if the patient starts to wear his retainers, the force from the wisdom teeth might push the 7 to 7, and he tends to get a little bit or a slight relax of the lower incisors. So usually with this type of teeth, I will always warn them and tell them that they need to keep their retainers on until they decide to extract their wisdom teeth. If they don't extract their wisdom teeth, they have to wear their retainers as long as possible. And usually with patients going abroad and patients that finishes with MA, I like to use Rivera with Vibrant. And about 90% of my patients uses Rivera 3 sets. I don't usually use the 1 set because 1 set is not good. Because if they have something emergent or they broke their retainer, they don't have any backups. And it's also good for our practice because they don't have to come in often. And it's good for us. And usually with Rivera, after we do it with scanner, it's very fit. It's very precise. So, in the earlier days, when I have retainers, the patient has to make an appointment to come in to pick up the retainer because I need to fix it. Because the suck down manufactured or created by our staff is usually not very fit. So I have the patient come in, I have to check everything is good, if it's not good, I'll do the hot bath water, or we learn with the fan to hit the aligner, to hit the plastic, the retainer, so that we're able to modify or to adjust the size or tightness of the aligner to fit better on the dentition. And he just flew to the Philippines with his Rivera, and I only see him every summer. He comes back. And look at his chin, okay, and his airway. Look at his airway. Can you see this one and this one? How much difference? This is scary. I've never, paid good attention on the airway before I do MA. No, never. Safe for me is not airway. Safe for me is SNA, SMB, AMB, and width, okay? But never the airway. Now it's the airway and it's also the CBS. Okay, you can check his vertebrae to see if it's at his peak of puberty. Look at his airway, that is very scary. And by doing this, you're helping him because you're expanding his airway, allowing him more volume or more oxygen to be bringing into his body. And it will help with his circulation he won't have, we call it a cold body. In Chinese medicine, if you have a cold body, you have a poor circulation, and everything won't be good. Okay? You get tired easily, your brain is lack of oxygen, you tend to be drowsy, it's hard for you to focus, you get sick because your immunity will decrease and your concentration will decrease, you don't sleep well, and even though you sleep 8 hours every night, you still feel very tired in the morning. So we are helping him not only with his nutrition, with his facial profile, but also his overall health. And the amount of overjet that's corrected, 8 millimeter in total, with an A, no elastics, okay? No distalization, no surgery, no activator, no Byrex. And this is his cephalometric. If you ask me, do I do the tracing myself? No. AI does it, okay? This is AI, and it will give you the report, okay? And this is called web safe, okay? Jot it down, WEBCEPH. You can just upload your cephalometric, and then you just need to jot the endpoint and calibrate the ruler, okay? But you need to know the deviation. For my cephalometric, it's 1.2. So for 10, it's 12 millimeter. 10 on the ruler is 12 millimeter. That's called calibration. So you need to check, the deviation of your X-ray and the real, the person. Okay. So after we superimpose, we can see there's a downward mandibular growth. Okay. And retroclination of the upper and lower incisor. This is very important because the side effect of functional appliance is labial tipping of lower incisor. However, with mandible advancement, we're able to keep the inclination, we're able to keep the torque and prevent more labial tipping of the lower incisors. And if there's more labial tipping, the side effect is the patient, it's hard for the patient to do more mandible advancement because the incisal edge of the lower incisors touches the upper singular, the lingual singular on the upper incisor. So it's hard for the patient to jump further. You need to change the inclination so that the mandible is more able to come out in a forward position. So that's the first case with excessive overjet. So now, when you go back to your practice, your clinic, and you are looking for someone that is overjet of 10 millimeter, and in his teen years, or in her teen years, and maybe you want to try MA instead of extractions, and instead of elastics, and you see the miracle for yourself, and for the patient as well. Now we're going into the next case. The next case is a deep eye. A very brachycephalic with hyperactive masseter muscle, in which when you see this type of face, okay, maybe one jump till the end, so he doesn't crush the wings. He is in his 16 to 17 years of age, a little bit older than the last patient, okay? You see, after I have a lot of teenagers, I tend to have kids that are more males than females. Usually I have more females than males. Now all the males are coming in. And usually with the males, sometimes it's really severe for them because the growth is slower than females. So they tend to, hide, men will tend to hide in a more distal backward position. So he has some posterior crowding here on upper 1/6, okay, lower 4/5 and 4/6, and deep overbite of about 80% or about 6 millimeter, with mandible retrognatism. Okay, the chin is facing downward and backward. And on class 2, here, about class 1 here, midline deviation. If you have one side class 1, one side class 2, the midline is always, usually, 99% off. I cannot say always, because if you have one incisor missing, maybe they will be on. But if the teeth are all the same on the upper arch and lower arch, if one side is class 2, one side is class 1, it's usually the midline is off. Then you would need a symmetrical jump to open up the bite and correct the midline. And this is very efficient and very comfy and very, I think it's very neat to use, because you don't have to pull transverse elastics. You're able to customize the different length of the precision wings to help with the transverse correction together with the sagittal. And not only the arch expansion, but also the midline deviation. It's also applicable together with the MA feature, the alignment and the leveling of the dentition, and also the midline. We did 2 clean checks for the patient, and the total treatment time is 2 years, 5 months. So this means there's something crooked on the posterior. Maybe we'll enter a stage called pre-MA. So the patient is a class 2, division 1, okay, almost division 2, but his incisors are more upright. 1/6, 4/5, 4/6 are a little bit lingual version. Deep overbite with narrow arches and a small chin. His overjet is about 6.2 millimeter. Okay, so in the final position, you finish the patient with a final position of overjet 6.2. It's not very stable because the lower incisor is biting on the cingulum on the upper incisor, and this cingulum here is very near the center of rotation. That's why this type of dentition on the upper arch will open, it will be gap. So we need to finish with the lower incisor biting on the lower 1/3 of the cingulum on the incisal edge. So he's about 6.2 over jet, 5.1 over bite. We want about 3.4 millimeter of correction on the upper arch and 5.6 on the lower arch, because I want overcorrection on the deep bite. He is a deep bite to start with. So the treatment plan is to do expansion on the upper right and lower right, okay? And correct the arch form into a wave arch form, and do more anterior intrusion on the upper arch and on the lower arch. If the patient is more gummy, we do more upper intrusion. If the patient is less gummy and the curve speed is large, you do more intrusion on the lower arch. For this patient, I do more on the lower arch. As you can see here, the curve speed tends to be large on the lower arch. And we want to correct the midline and MA with a symmetrical jump. MA with a symmetrical jump because there's the difference in the length. We need to train and to teach our patient to advance the mandible and position the mandible in a more forward position before he engages the wings inside his mouth. So you can ask the patient to move the mandible in a more forward position. Practice, okay, like 20 times before he wears his aligners with the MA. It will help him better sit the MA in position. So let's take a look at his clean check. So on the first clean check, the same, 6, right? 6 point something. 2 millimeter in front of upper incisor. That is the final position. And after I start to do this, I have more, better result at the end of MA treatment. Otherwise, in the early days of MA, I usually find it not enough. the mandible position can be more forward. It's always not enough. So I changed after some experiences with the MA appliance. Take a look after 1 year, okay? He's a bit older, he's about 16.5 months, I guess. It takes him about 1 year, okay? And his muscles are very heavy, strong masseter muscles. This side is good. This side is not too good, right? Because the MA gets crushed on his treatment, and during his treatment, even though the D5 is a little bit corrected, about 1 to 2 millimeter here, okay, but not much. Okay, so we continue. I asked him, okay, to do more mandibular advancement exercise. But during this stage, we can see the palatal cusp hanging down here. So the bite here is not too good. The buccal overjet is big. So overhanging palatal cusp is very common in distalization, in expansion. And you will see when you move buccally or you move distally, the cusp will hang down and it will induce interference or collision with the buccal cusp on the lower arch. And the reason for this are either these three reasons. The expansion is not fully expressed clinically, and there's limited alveolar ridge or lack of buccal root work. And reason number 3 is usually the most commonly seen reason in palatally hanging down cusp or overhanging palatal cusp on the upper arch. It's usually due to lack of buccal root work when you are doing expansion, lateral expansion, or distalization. So we can increase the buccal root work so that we are able to keep the palatal cusp from hanging down and giving the buccal surface a more lingual root work. So this side can come more to the lingual side and allow a better intervegetation with the lower molars. And luckily, after AA, he is a very slow wearer, okay? We're able to adapt his midline and make it coincident with each other on the upper arch and lower arch. And that is Mother Nature. If the canine are on and the patient has no Bolton discrepancy, the midline will be on. If the canine are class 1, the midline is not coincident with each other, there is Bolton discrepancy. It's impossible to make the upper and lower midline on with each other if the canine are already on. Okay? So don't promise your patient that, oh, you're going to help him correct the midline. If you correct the midline, you're going to destroy the canine relationship. And I will always select the canine relationship more than the midline. I don't have midline on with each other. Okay? In order to get the midline on with each other, it has to be very very particular, everything has to be right. The size, the morphology, the relationship, okay? But sometimes it's good, sometimes it's okay or all right if the midline are not coincident with each other. Because now with the marketing, with a lot of information on the website, patients think it is wrong, or it is not correct, or it's something, there's something wrong, with your treatment because your midline is not on. And I have patients that come in asking for a 0.05 millimeter change of midline. Okay, he will tell me that he still needs 0.05 millimeter of midline. He measured with a very small ruler and tells me that he wants it on, with the upper midline, and that's crazy, because us as dentists, we are not computers. So it's hard for them, hard for us to do all those adaptations. Now, with the feature of differential and asymmetrical advancement of the lower arch with a precision wing. It's very promising for midline issues, okay? Especially in kids in the mixed dentition, in which they are not very compliant in using the elastics. You can use the MA as a source of transverse correction to correct the midline and adapt the midline. So this is one of my younger patients, and you can see here. Okay, he still has his baby teeth, deciduous teeth. Okay, and then as we are, decrowning on the upper arch and correcting this, leveling and alignment, we try to adapt his midline without him using any elastics. We put on the MA for a short time, and we utilize the asymmetrical advancement, okay, to help with the midline adaptation on the upper and lower arch. So can you see the mandible advancement comes in after some aligners? So the first few aligners are the pre-MA phase. And with the pre-MA phase, it takes 4 aligners, at least 4 aligners. So if you're going into the pre-MA phase, you cannot just have 1. You will have at least 4 aligners. Just like MA phase, you will have at least 26 aligners. You cannot have anything less than that. If you're using MA, you cannot use anything less than 26 aligners. If I'm not wrong, I assume it's 26. So let's take a look here. So you can see that MA does not come in after stage 7. Okay? So we do the expansion of the upper 6, lower 5, and lower 6, and after it's more aligned in the arch form, the system gives the mandible advancement. Now with the clean check, I think it's very safe in doing treatment because they have a lot of warnings and a lot of calculations and algorithms to help us foresee whether we are in a good position or we are in a good treatment with the patient. If you have heart collision, the software will detect and they will let you know. They will ask you, do you want to free the occlusal interferences or the red occlusion at the end of the treatment? And if you have teeth are still crowding and you want to put MA, the system will not allow that. They will reject, okay? And they will tell you, oh no, not MA now. You need to level and align the posterior before we can trigger the MA to the patient. So expansion and decrowding simultaneously with MA treatment. So there's no time wasted. Everything is efficient, everything is planned, everything is precise, everything is according to the plan. Now, doing orthodontic is not when the patient comes back, you look at the patient and then you do what you see. Now is you foresee the future at the beginning. So you begin with an end in mind at the beginning. So you know, and you get to learn more about how teeth movements move in any patient. And you are more able to understand the biomechanics of different types of tooth movements. Intrusion, extrusion, distalization, expansion, flattening of curved teeth, derotation, okay, marginal ridge adaptation, and all those types of different tooth movements. Because you can see visually, clearly, with the 3D model, with the clean check modification, buccally and lingually. I am trying to change my habit nowadays for the past 2 months. We tend to look at the mouth clinically with our patient, even if we scan. So we scan, we look at the mouth, and then we look at the scan. Now, I scan, I look at the scan first before I look at the mouth. Because usually we will tend to see less with our eyes intraoral. But with the scan, we're able to flip. And usually, when I check the scan first, I will see the caries on the distal of 7, in which I don't usually see in the mouth. And I can tell the patient, oh, you have those cavities and you need it fixed. So, scanning, trust your scanning because it's very precise and it's there. And images are good and sharp and very clear. And now with the Align Oral Health Suite, I also use it. I use it a lot for the occlusion, for the bite, the heat map. Okay? In patients that are deep bite, anything red, I will tell them, and there's the evidence that they need to be careful that after treatment, maybe they need onlay or monlay. As you know, monlay, onlay plus inlay, okay? It's very popular in our market because more protection. And usually, patient with deep bite after treatment, because you you elevate or you correct the vertical dimension. There's a clearance, there is a space, and you need to fill the gap. And with the gap, you are restoring the missing occlusal surface in deep bite patients. And usually they will need an onlay or a monlay. So this is the patient on the upper arch and lower arch and changes. And his changes in the smile. Look at him, totally different in muscle balance. Not only the smile, but the muscle balance is totally different. His change in his chin button, because he has a less overjet discrepancy to start with. His facial profile is better at the end of the treatment. You can see that the chin button is better than the last patient. And its growth is much better. The lower lip is more, it's advanced more anteriorly. He's a good patient. Even though he doesn't wear his aligners, as compliant as the last patient, but he listened to me. He has his wisdom teeth all extracted before putting on his Viveras. And this is changes in the cephalometric, okay? The upper and lower incisal inclination. And look at his airway. Okay? The hyoid bone, and that, and there's more clarity in the airway. Now go back, always check the airway in your patient. Okay? Even if you don't do myofunctional treatment, after the advancement of the mandible, you are able to expand the airway. And together with myofunctional exercises, it will add to the effect. However, if you only do muscle exercise, it's not going to help. If the mandible does not advance, the airway is still collapsed. So myofunctional exercises has to go hand in hand together with dental treatment, with orthodontic treatment. And it will, win-win together. But together with only muscle function, you are only able to correct the mouth breathing to nose breathing. But with this type of airway, it's hard to correct with only muscle exercises. So we're able to correct the overjet from 6 millimeter to 2 millimeter. And they are all very stable because most of my patients, they come back every 6 months for a dental, for routine retainer checkup. So usually they come and pick up their Viveras at the front desk or reception, and they come back. The first follow-up visit is at 6 months after the Vivera wear. And they all understand because our staff will instruct the patient, will train the patient to put on and take off and give them the instructions on how to use the Viveras. And if they have any problems, they're all able to communicate and contact us, not through the phone, through line. Okay? And even if they send us a message at night, the next morning when our staff comes into the clinic, they are able to process the messages and the issues that the patients are facing. So it becomes very convenient. The patient does not have to come in for just, a little ouchie and a little, crush there on the aligner. Our team is there to support the patient. So for him, there is an increase in the lower facial height, okay? And intrusion of the lower incisors. The blue